I'm Marcia Childless from the Center for Biomedical Ethics and Humanities here in the School of Medicine, and welcome to all of you here in advance of the snowstorm. We are especially happy that we have a speaker here from Washington, D.C. who's going to be able to not only get here, but get home before, we hope, before the snow starts. At a time when lesbian, gay, bisexual, and transgender LGBT individuals in the U.S. enjoy unprecedented social acceptance and legal protection, many LGBT elders face daily challenges of aging, isolated from family, detached from a larger community, and ignored by mainstream aging initiatives. These elders are more likely to be single, childless, financially insecure, fearful of encountering bias in healthcare settings, and socially isolated. And the continuing silence surrounding LGBT elders has left many of them underserved and at risk. Our Medical Center Hour today makes the case that increased cultural competence measures are necessary in medicine and in society to help older LGBT persons overcome barriers to successful aging, and to ensure that we are all taking good care of our LGBT elders. We welcome today Nancy Nauer, the I. Herman Stern Professor of Law and Director of Law and Public Policies Programs at Temple University's Beasley School of Law. She's internationally recognized for her work as a legal scholar in the areas of identity, sexuality, and gender. She's author of the 2010 book, Gay and Lesbian Elders, History, Law, and Identity in the Identity Politics in the U.S., and a number of other articles, and you find a lot of resources related to this subject in your handout. We also welcome UVA's own Chadwick Lane, a member of the medical school's soon-to-be graduated class of 2014. Chad will offer a brief response to Nancy Nauer. You'll find short biographical sketches of both speakers in your handout. Also, I should mention that both speakers have completed conflict of interest disclosure forms, and neither has disclosed any financial conflict of interest. I'd like to mention we're proud to have as our co-sponsor of this program the Student Club QMD, which serves as a forum for LGBT issues in medicine and seeks to raise awareness of topics concerning LGBT patients and medical professionals. And there's information on your handout about being in contact with QMD. So we welcome Nancy Nauer and Chadwick Lane and a good hour's discussion of taking good care of our LGBT elders.
Great, thank you very much, Marcia, and I just want to thank everybody here at the University of Virginia for including this topic in your Medical Center Hour. As Marcia mentioned, although there have been tremendous gains in LGBT rights with respect to marriage equality, employment non-discrimination, and also with respect to the needs of LGBT youth, what we find is that the LGBT rights movement has been relatively silent regarding issues involving aging and specifically LGBT elders. This invisibility from both the LGBT rights movement and the mainstream aging movement has left our LGBT elders in a precarious situation. So today I'd like to talk a little bit about the barriers that LGBT elders face to successful aging, specifically some legal barriers, and also some things that LGBT elders as well as service providers and medical professionals can do to maybe help them age successfully. So let's see if I can make this work. I'm not sure. Yes, there we go. And Marcia mentioned in the beginning some of the barriers to successful aging that we see faced by LGBT elders. And one of the things that when you think about a lot of what's been said about LGBT rights in general, it really stresses how much LGBT individuals are the same as everybody else, right? They're just like everybody else, so they deserve equal treatment. And one of the things that we have to focus on when we're talking about LGBT elders is they are different in some significant ways, different from younger LGBT individuals, and also different from their non-LGBT peers. So we have to remember that LGBT individuals, because of when they grew up, because of the time when they came of age, they are much more likely to be single. They are much more likely to be estranged from their family of origin. It would have been very common in the 1950s and 1960s for your family to disown you, or for maybe you to self-estrange from your family. They report higher levels of health disparities and higher levels of financial insecurity. They are also much less likely than younger LGBT individuals to be open about their sexual orientation or their gender identity. This reluctance to be open about their identity can lead to all manner of issues. Now, the invisibility of LGBT elders, I think, might seem a little strange, given, again, the strides that have been happening with regard to the LGBT rights movement. The person that you see on the screen is Edie Windsor. She was the named plaintiff in what's been considered to be one of the largest civil rights cases of our generation, U.S. v. Windsor. And Edie Windsor is an 84-year-old widow. She and her partner were together for over 40 years before they were finally able to marry. Her partner had been diagnosed with a terminal illness. They traveled to Canada, where they were able to legally marry after what she called a very long engagement. If you're interested, there's a very cute moving documentary that you can get on Netflix, and it's called just exactly that, A Long Engagement, talking about their 40 years together. Now, Edie Windsor is atypical, perhaps, in that she is out and proud and willing to stare down the U.S. government. The case that she brought happened because when her partner died, she received a tax bill from the U.S. government for $336,000, $1,000 that she would not have received had her partner been a man. Edie said repeatedly in interviews, if her name had been Eddie and not Edie, this would not have been the case, and she took the case to the Supreme Court. What the case did was it invalidated the federal definition of marriage. So now if you are legally married in the state where you live, then you will be considered legally married for federal purposes. One of the interesting things about Edie's case, though, is that in her brief, she told the court what it was like growing up knowing that you're gay in the 1950s and early 60s. And she talks about, very movingly in this court filing, about how afraid she was when she worked for the Atomic Energy Commission and they were calling her in to review her security clearance. And she knew that if they found out that her partner was a woman, she would lose her job and she would lose her security clearance. Because actually until the early 90s, homosexuals were not granted high-level security clearances because they were considered to be, well, one, undesirable, but two, also a potential blackmail risk. Edie quickly left government service and went into the private sector after that. But she also talks about in the brief about how when they were deciding to get engaged, let me try this, and move in together, that they knew that she couldn't give her partner a ring, that they couldn't possibly exchange rings, because then their friends would ask them, oh, are you engaged? And so instead of a ring, they settled on a brooch, and something that was very personal between them, and that when they would see it, they would know that of course they were engaged, but it couldn't be anything that would signal to other people. So even in this victory that we have before the Supreme Court, you can see in the court papers Edie Windsor talking about what it meant to grow up in what we refer to as pre-Stonewall America. That is, an America that existed before LGBT individuals said, hey, I'm okay the way I am. And as we're going to talk about in a minute, started to lobby the medical profession. So, as I said, LGBT individuals today unfortunately don't all share Edie's openness, her strong support from family and friends, and they often exist as a particularly vulnerable population. In fact, HHS, the Department of Health and Human Services, last year recognized that LGBT elders qualify as a population of greatest need for purposes of the aging legislation that HHS implements. As I said, more likely to be single, less likely to have children, likely to be estranged from their family of origin, high levels of disability, high levels of financial security. A same-sex female couple is twice as elderly female couple is twice as likely to live below the poverty line than a non-LGBT heterosexual couple. In addition, one of the things we know is that they greatly underutilize senior services. So as we're going to talk about in a minute, LGBT individuals are especially fearful of assisted living facilities or congregate living facilities, places where they're going to be in contact with basically strangers. And they will go to great lengths to what's referred to as age in place. When they age in place, however, they're also often afraid to access the same sorts of supportive services that we have for elders trying to age in place, which puts LGBT elders at an enhanced risk of self-neglect and also social isolation. Social isolation being a term of art, meaning it's the condition when you literally have no one to call. There's no one that you can call to pick up that prescription, to drive you to the doctor's office, to just say, how are you? Part of my frustration about the way that the LGBT rights movement and the aging initiatives have dealt with these issues is that so much has been done for LGBT youth. Many of you are probably familiar with the It Gets Better video project. The It Gets Better video project is something that was started because of the very high and alarming rate of suicide and self-harm among LGBT and questioning youth. Everyone, it seems, has done an It Gets Better video. President Obama has done an It Gets Better video. The Secretary of Agriculture has done an It Gets Better video. The 49ers as a team has done an It Gets Better video. Every member of Glee has done an It Gets Better video. But one of the things that we can see is that all of the concerns that we have for LGBT youth apply equally to our LGBT elders. That there are concerns, there are health disparities, there is self-injury, there is high rates of suicide, but there are no videos for our LGBT elders. And several people have suggested that if we want to have truth in advertising, we could tell people that it gets better, and then potentially it gets a whole lot worse. But anyway. So, briefly, and I'm sure you're all aware of this generally, that the United States is a patchwork of marriage recognition laws. That currently 38% of the population of the United States live in states where there is marriage equality. In other words, live in states where same-sex couples can legally marry. The Commonwealth of Virginia is not one of those states. And although we have 18 states with marriage equality, we have 34 states that continue to ban marriage between, continue to restrict marriage to only between one man and one woman. To further complicate matters, there are some states that have sort of things that are in between. Civil unions, domestic partnerships that will often give you all the rights of marriage but are not called marriage. To further complicate things even more, your marriage status tends not to be portable. So that if you are married in the District of Columbia, as soon as you go, right, if you're on the metro and you're in the District of Columbia and you're like, oh, I want to go to Costco in Alexandria, as soon as you pass under the Potomac River, you are no longer married. Moreover, your children may not be considered legally your children if you were not the biological parent. For LGBT elders, this is another layer of minority stress that is added because when you think about it, you have to worry about not just whether or not you're married in your state, but certainly any plans to retire to, say, Florida or Arizona would make you not married there. And so actually the American Psychiatric Association, when it first came out in 2004 in favor of marriage recognition, it specifically cited in its resolution this notion of minority stress, the idea that not only do you have to sort of live your days and figure out, you know, how to get from one day to the next, but you have this whole legal apparatus on top of you trying to figure out when you're married, when you're not married, and good luck trying to figure out how to file your taxes, right? So I am a tax lawyer by trade. I won't bore you with that, but suffice it to say that same-sex couples really do have to have a tax lawyer sort of on call all the time, because you can be married in your state, you can be married for federal purposes but not married in your state. So if you're a same-sex couple who live in the Commonwealth of Virginia and you go to DC to get married, you will be married for federal purposes but not married for Virginia purposes, which means you have to file two completely different sets of taxes. Anyway, that's just an example of some of the legal obstacles. Obviously in the states where your partner cannot be your spouse, not only are there tax issues, but there's also issues because if you were to die, say, without a will, your partner would be considered simply a legal stranger. If you were to need a guardian appointed, your partner, in the absence of marriage equality, would be considered a legal stranger. Same too with hospital visitation rules and the like. So the marriage equality, especially for elders, is a way of securing and building family. Okay, let's see. So I mentioned Stonewall a little bit earlier, and I said that Edie Windsor's brief that she filed with the Supreme Court gave us a glimpse of what it was like to grow up in what's referred to as pre-Stonewall America. That is, an America pre-1969 when homosexuality was criminalized, and it was actually classified, you probably know this, as a severe sociopathic disorder and was included in the DSM. And there was a whole range of treatment that was available for homosexuality. And in order to cure one of homosexuality, there was aversion therapy, electroshock therapy. There were reports of lobotomies occurring in the 1940s. You could be involuntarily committed. You would lose your job, and you would certainly lose your children if you had children from a prior relationship. In 1969, we usually see that as the beginning of the LGBT rights movement. For LGBT elders today, they were 20 years old before there was ever any sort of public, sort of pro-gay statements being made. So that if you think about someone who comes of age at a time when they are criminalized, they are sick, and they are certainly a sinner, that has a significant effect on their worldview. As you can see, homosexuals, if you just, the medical literature from the 1940s, 1950s is fascinating about efforts to first identify and then cure homosexuality. To the extent homosexuality was considered a severe sociopathic disorder, obviously you were not a fit parent, and obviously your employer could fire you from your job. I stress this because of the importance that history plays in the current lives of our LGBT elders. Because again, think about coming of age when, nowadays, right, everyone has seen Glee at least once, right? And, nowadays the question is, how are you going to come out, right? We just have an NFL star, prospective NFL star. We have a college football player. And I was listening to CNN radio on the way down, and part of the news story was how he came out to his father via text. I would not advise that, anybody. Via text, and his father was going to be on CNN to discuss how he reacted to it. So these days, we sort of talk about coming out as this sort of rite of passage. It's like, how did you come out? Who did you tell? How many people in your life know? Prior to, certainly Stonewall, and prior to 1973, when the American Psychiatric Association voted to declassify homosexuality, there was really no discussion about coming out. If you came out to your parents, they could kick you out, or worse, they could have you involuntarily committed. Because if you came out to your parents, you had just told them that you were severely mentally ill. And many parents at the time, many homosexuals, which would have been the word that would used at the time, desperately wanted to cure themselves, right? Desperately wanted to be normal and not, as the last slide had said, different. This is the 1971 APA conference where homosexual, actually they were called homophile activists at the time, were lobbying to try to get homosexuality declassified. The person in the mask is the only psychiatrist at the time who would speak on the panel or in support of the, who would speak on the panel and self-identify as being gay. He could not risk showing his identity. He was known as Dr. Anonymous. It is Dr. Fryer who died in the early 2000s. I think you can see from the headline next to that, that when in December of 1973, when the APA voted to declassify homosexuality, 20 million gay men and women were miraculously cured. Interestingly, ego-dystonic homosexuality stayed in the DSM until 1989. And that basically meant if your homosexuality made you feel bad, then there was still something to be said. The history that today's elders live with, right? When you think about it, if we're using elders in the traditional term as folks who are 65 and older, they were 24 before they were cured. They have been described as the last generation who lived their life in hiding, right? Who grew up hiding this really essential part of themselves. And what we find is that this experience continues to have a salience today for our elders. We find that even elders who have been relatively open in their life, as they get older, become more closeted. These are the folks who perfected the closet as an adaptive strategy, so that we hear remarks about folks going back into the closet, certainly if they're going into an assisted care facility. Some elders have never actually been out of the closet, right? Some elders would not identify as LGBT at all, but would identify perhaps as homosexual, perhaps as gay, perhaps as having a very close relationship with someone of the same sex, but not necessarily as LGBT. And we also find that this history complicates their relationship with healthcare providers because they will not disclose. They will not disclose because they are very, very fearful of encountering LGBT bias. Because remember what we just said, they were mentally ill until they were 24. This is the same group that could be involuntarily committed. So the experience and the relationship that they have with healthcare providers is very complicated. Finally, I've been told by social workers and gerontologists who study this issue that LGBT elders often will not stand up for themselves because, well, when they were growing up, this is actually how they heard it was going to end. If they didn't straighten out, literally, they were going to die alone. They weren't going to have a family. Is that what you want? Do you want not to have a family? Do you want to die one day alone in a single room? And there is this self-fulfilling prophecy that again goes into the potential for self-neglect and social isolation. So, just again, all the high points. Right? I'm sorry, I don't mean this to be as depressing as some of you are. There are high spots. It's coming. Okay, so I want to make the point about history. I also want to say something about research. And it goes to this invisibility. There is no national data set on LGBT elders. We just don't know enough about LGBT elders, and you can sort of think about why that might be true. To some extent, no one likes to talk about senior sexuality, so maybe it's sort of, it's like, oh, well, old people know, just don't tell me. That somehow older people are asexual, so we're not going to ask those questions. There's been sort of resistance about querying sexual orientation or gender identity in large surveys because you don't want to make people feel uncomfortable, right? You don't want to invade their privacy. Of course, to the extent that this has continued to be seen as sort of a private issue, it is, I think, probably tinged with shame a little bit and not going to the openness and the communication that we need. But that said, there are some things we know, right? So we need to have more research. We need to have questions about sexual orientation and gender identity asked in large surveys. We need providers to just capture that information. When area Aging organizations were recently surveyed about how they deal with their LGBT clients. Many of them, a significant number, said, oh, we don't have any. And it's like, no, you have them, you just don't know. Right? It's like, no, we don't have any. No gay people here. Right? I can't see them. But the little bit we do know from research that we can piece together from the census, because the census will report same-sex coupled households, and you can figure out how many of those are elder based on the census. We know that there are same-sex elder households in 97 counties, 97% of all counties in the United States. They are everywhere. 15% of those same-sex elder households are in parts of the United States that are considered rural, where there are going to be very, very few supportive services for LGBT individuals of any sort, let alone LGBT elders. We know from the census that they report significantly higher levels of disability across all categories of disability that are queried on the census. We know, as I mentioned, that same-sex partnered elder female partners, it's a lot of words, are twice as likely to live below the poverty line as married husband and wife heterosexual couples. We know that on all economic indicators, LGBT elder couples lag behind their non-LGBT peers. It's particularly stark when it's two women, but all of them, even two men, which sort of goes to, I think there's a myth of gay affluence, especially if you watch, things on television, like the Modern Family or the New Normal, and it's like, well, two gay men, rich, blah, 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 nice house. That's actually not true, especially for this generation. Because remember, this generation really are the longtime survivors of homophobia and transphobia in the workplace. In addition, since they are estranged from their families of origin and are less likely to have had children, LGBT elders rely on something that anthropologists have called chosen family. And when you think about it, if your parents find out that you're gay, they're going to disown you. So you move to a big city and you self-estrange, or maybe they do disown you. What anthropologists will tell us is that gay men and lesbians in the 50s and 60s created chosen family, friends as family. And they're a very supportive, creative way of creating community in a hostile society. The problem with these chosen families is they almost always tend to be single generational. Right? So that people who are your chosen family are all your same age. In the United States, 80% of all elder care is done by informal caregivers. Informal means unpaid. They are almost always younger family members. So for LGBT elders, when their chosen family ages, they all age together. And it creates overlapping and reciprocal caregiving responsibilities. And remember, this is the same group that is going to go to great lengths to age in place, not use supportive services. Add to that the legal obstacle that chosen family are mere strangers. So chosen family is not going to have any legal right to property, to medical decision making, to hospital visitation, which means that it is essential for LGBT elders to do sort of the full range of estate planning that is sort of a luxury, right, for opposite sex couples. Right? 2/3 of all people in the United States, they die without a will. And, I'm a lawyer, so I want everyone to have a will. But, if you die without a will and you're in a traditional relationship, it's really no big deal, right? Everything's going to go to your spouse or everything's going to go to your children. But if you're in a chosen family situation, and if you die without a will, the property isn't going to your closest friend. It's going to your cousin in Duluth that you haven't seen in ages. And more importantly than your property, what happens if you become incapacitated or start to experience cognitive difficulties? Who is it that stands, that has legal standing to help you, to make decisions on your behalf? So, chosen family was a creative way to create community, but it's a very legally fragile way, and it is also a community that will age together and not have the benefit of the intergenerational support that many of us have. So we talk about LGBT elders are saddled with history. There are clear disparities that we know. There is a need for continued research. And then there is what we hear again and again from LGBT elders, that they are very fearful that they are going to experience LGBT bias on the part of service providers, on the part of medical professionals, on the part of other residents in long-term care facilities or assisted living facilities. And as a result, they will become closeted. And they've been referred to as Gen Silent. So we have the greatest generation, we've got the baby boomers, and LGBT elders are referred to as Gen Silent. There have been a couple large surveys done to talk about the extent to which LGBT elders do encounter bias. And one in particular deals with the bias encountered in long-term care facilities. And it seems like our LGBT elders are right to be fearful of these organizations. One of the things you might have heard about in the news, right, is that when you look at demographics, younger people support same-sex marriage and LGBT rights in a much greater percentage than older folks. And one of the things that is really clear is that 65 and older is the generation with the highest level of anti-gay, anti-transgender beliefs. So, when those are the folks in the assisted living facility, and you're an LGBT elder, it makes sense that you're going to encounter problems with some of the residents. And we've documented shunning behavior and bullying behavior, just like, as I said, LGBT youth experience in schools. Only this is, school is one thing, this is where you live. We also know that sometimes service providers will refuse to touch LGBT elders. They won't provide them the same level of personal care. Transgender elders are especially vulnerable to this. Transgender elders, for reasons we can talk about afterwards if you'd like, it's relatively rare that a transgender elder would have had conforming surgery on their genitals, which means that a transgender elder actually can't go into the closet. Because anyone who is performing personal care is going to notice that there is dissonance or disconnect, apparent disconnect, between genitals and gender performance. And transgender elders have been forced to wear the wrong clothing. You will have staff refuse to call them by their chosen pronoun, refuse to call them by their name. And if you add a little bit of cognitive disability there, or issues, you can see that for transgender elders, an assisted living facility, especially a sex-segregated one, it is going to be a very, very difficult place. You also have reports of facilities just not recognizing powers of attorney and the like. And then finally, and I think most disturbingly, in 2007, the New York Times reported a case where residents were complaining about a man who was, I guess what we would consider to be sort of obviously gay or flamboyantly gay, one of the residents. And some of the family members had complained as well, right? They didn't want dad in here with that fruit, right? So what they did was apparently an industry practice, and that is that they moved him to the dementia or the secure memory ward because the people in there won't complain. And the gentleman was what we would call an unbefriended elder. He didn't have anyone that he could ask for help, and he eventually committed suicide. And again, I go back to this is the generation that could be institutionalized against their will when they were young, and to see it replicating again. The closet, to some, and the one other thing is sometimes religiously motivated caregivers will harangue LGBT elders. And this is especially difficult if someone has limited mobility. And especially difficult if you have the beginnings of dementia. That caregivers will urge them to repent and make things right now while they still have a chance. The closet, I want to say just a couple things about the closet quickly, and that is that to some extent it's like, well, you just sort of keep things quiet, don't ask, don't tell. But when you think about it, it's a lot more than that. And when folks go into assisted living, or when folks have a home health care provider come to their house, they take down all their pictures. They have to de-gay the house. If you're in an assisted living facility and you're going to go to lunch or dinner with the other residents and you're going to talk about your life, well, are you going to talk about your partner? What we're told is that LGBT elders in those instances actually make up another set of stories so that they can still tell people, but this picture would be with their best friend and not their partner, or with their cousin and certainly not their partner. And the chief of geriatric psychiatry at a large New York City hospital explained to the New York Times that closeted LGBT elders face a faster pathway to depression, failure to thrive, and even premature death. And that there is something wrong about being at this stage of your life and having to hide something that was so important and so central to you. And a lot of times, again, people think, well, it's don't ask, don't tell. But it's actually, I think, the possibility that you could have our LGBT elders seriously alone with their memories and not being able to share them. I just want to end with a 2008 story about Clay Green and Howard Scull. They had lived together for 25 years in Sonoma County, California. Not, California. Sonoma, Clay was 77 and Harold was 84. Harold fell, and over Harold's objections, Clay called 911. And 911 came and took both of them into care because they didn't think that their house was quite as clean as perhaps it should be, right? I don't want anyone coming to my house making that decision. And they put them in separate, secure facilities, dementia facilities. Harold died 4 months later. Clay didn't know about it for days afterwards. By the time Clay was able to by the time someone missed Clay, by the time he was able to get word out, and get representation. The county had sold their house, destroyed their cats, Sassy and Tiger, and all of their possessions. And Clay's attorney says that he worries constantly that the county workers are going to come and get him. Sonoma County settled 2 days before trial for $600,000 and promised to put in place cultural competency training, because as I think Chad's going to talk about in a minute, one of the problems was that the ambulance folks and the EMTs and the doctors and the psychiatric social workers at the hospital did not recognize them as a couple. And indeed, in interviews, Clay will just talk about his best friend. He does not actually say, because this is not what the generation would have done, I am gay, I'm a gay man. He just doesn't talk about that. With that, I just want to say that with proper cultural competency, anti-bullying rules, just increased visibility, we can make sure that this generation of LGBT elders ages successfully, and certainly make sure that it's not something that the next generation of LGBT elders has to face. So thank you so much.
Thank you, Nancy. That was great. It's a really important message. And before I start, I'd like to say thank you to Marsha Childress for having us at this event today, and a huge thank you to David Richards and Sammy Bishop, who are our current co-presidents of QMD. Nancy mentioned earlier that she would recommend coming out to your father, mother, parents via text message. I came out when I was a second year here at UVA, and I hadn't come out back home, but I had a lot of friends here, a great support system. So I felt very comfortable here at UVA, and I was passionate, excited. I wanted to make a change, a difference in the community here, so I ran for vice president of the undergraduate student group, the LGBT student group. Well, I didn't know that the next day that they were going to be publishing our faces, the new officers on the university newspaper. So 2 ways not to come out to your mother: text message and on the front page of the news. So I do want to take a few moments to share with you my perspective. That's one of a soon-to-be practicing physician, one of a mental health advocate, a gay rights advocate, and a 27-year-old gay man. It's encouraging to see folks bring to light the seldom discussed issues that we just heard from Nancy, and it's certainly a discussion I hope to continue for a long time after. As Nancy mentioned, many of the issues that are pertinent to the LGBT community span the entire life. My generation of healthcare providers, be they physicians or bedside or advanced practice nurses, social workers, what have you, it is my generation that is tasked with leading the effort to provide better care to these patients. We're in a different world than we were 50, 20, or even 10 years ago. I can remember fall 2004. I was a first year here then. I'm starting to feel old. And I watched the news come in, state ballot initiative after state ballot initiative, declaring me a second-class citizen. I can remember my eyes welling up with tears. But as we know, with all great societies, time brings progress. And now a different story is being told, one of equality and inclusivity. And this story of human rights is told on many fronts, and a major one being our healthcare system. So, from a provider perspective, what can we do? What is our professional duty? Do you sleep with men, women, both? Do you have a romantic partner? Words have power. And these are the types of nuanced questions that cultural competency has given rise to. Being aware that every patient that comes through our ER, our OR, or our clinic doors is not heterosexual is an important step, but it isn't crossing the finish line. And as healthcare providers, we have the opportunity, we are positioned to have a far-reaching influence in this community. But exactly how do we do that? Just months ago, our televisions and our computer screens flashed stories of one life after another lost too soon to suicide. Gay, lesbian, and transgender youth ending their lives far too early at the hands of senseless bullying. We can change this. According to the Fenway Clinic in Massachusetts alone, nearly 30% of LGBT adults smoke tobacco. That's twice the rate of non-LGBT adults. We can change this. 20% of homeless youth are LGBT. We can change this. And a 2008 Substance Abuse and Mental Health Services Administration survey found that substance use rates in LGBT adults are 2 to 3 times that of the general population. We must change this. The first step to changing these realities, though, often sounds easier than it is, and it proves to be a huge barrier to providing good quality care. We have to ask the tough questions. We must help our future patients through their reservations, through their fears, through any shame they may be harboring. To do this, though, we have to be aware of our own reservations, our own fears, and our own shame. And I mean that quite sincerely. You can't be truly empathic, you can't be truly aware unless you do a lot of introspection. Now, part of that awareness is born out of events like today, coming together interprofessionally to talk about these public health issues in a very public forum. To enact change, though, you have to start early, and the University of Virginia and places like it across the nation are doing just that. Here at the School of Medicine, the LGBT Advocacy Group, or QMD as we've been talking about, with a lot of support, amazing support from the Office of Medical Education, and in particular Dr. Randy Canterbury, has a very active and ever-growing presence. When I started my first year here, I can remember being approached by the administration to develop a student work group, come together and brainstorm health topics that should be introduced and covered throughout the entire LGBT curriculum. And it was unique in the sense that it wasn't just atypical cases that we wanted to talk about these issues. We wanted to really normalize the idea of LGBT patients being under our care. So it wasn't necessarily any time that we talked about sexually transmitted diseases, or in often case HIV and AIDS epidemic. But in the sense of you're treating a child for acute sinusitis and same-sex parents come into the clinic. What do you talk about? How do you ask the appropriate questions? And some other things that QMG does and does very well. Every year for National Coming Out Day, we prepare baked goods and hand out support pins, which is always received with open arms by our administration and our peers. And now that we have an annual Charlottesville Pride Festival, QMD has had a presence working with health screenings and handing out medical literature. With a state-of-the-art facility and now 4 years into its innovative curriculum, UVA is poised to create and help train a new type of healer, one who is holistic, astute, and comfortable with the patients we've been talking about today, the future patients, the people of the LGBT community. So before I finish, I want to stress one thing, and that is that anyone in this room or in this school, in this institution, in this country, who is a provider has a very, very privileged opportunity. Our patients come to us for many reasons, but they are always looking to leave with just one thing, no matter what the diagnosis, no matter what the treatment. They're looking to leave that office, that OR, or that ER, with one thing, and that is trust. They want us to be a trusting, caring soul. And sometimes the healer is the only one who can fill that role for them. That is a very, very powerful thing. Value that, because it could be a remarkable agent for change. Thank you.
Thank you both. We have some time, just a few minutes for some questions and comments, and both Chad and Nancy are available to take your thoughts. Let's student. Questions?
Has anyone had, I'll ask the audience, has anyone had any experiences with patients in a setting between provider and patient that have been LGBT that you think taught you an important lesson? I'm looking at my medical student colleagues up there.
Tell us who you are.
I'm Sam Beck. I'm a fourth-year med student. And this kind of related to your question, Chad, but a question of my own, thinking of an experience that I've had, your sinusitis example made me think of it. Seeing children in clinic who had a mother come in, this actually happened several times, and then someone else who we suspected was probably the mother's partner. But I guess to my surprise, the unwillingness to say that, unless maybe they weren't, and I was just totally wrong all of these times, but it kind of did seem to make a difference in that moment of how I asked the questions, who I addressed them to, sort of whose opinion out of the two, if they differ, I would be more willing to believe. Maybe one of them spent more time with the kid than the other. And I didn't feel comfortable bringing that up because they didn't. Is this something that you think is best practice? Should that be something that I should be bringing up with them? If I think that, like, strongly suspect that they are, and I think it actually kind of might matter for what's going on, and how would I even broach that if it seems like that's not something that you want to just come right out and talk about?
Sure. So I guess the first thing I'd ask is, when you phrase your questions in a certain way, do you feel like that sort of moved the conversation and the interview along in an appropriate way?
You mean with the way that it ended up playing out?
Yeah, the way, yeah. Or do you feel like it was hindered?
I think it was hindered.
So, whenever I've been in those situations, and if I were on the other side of the situation as a patient, I think just asking, so what is your relationship with the patient is always very appropriate whenever there's more people in the room. That's always a safe way to do it. And then exactly what it sounds like you did, making sure to be sensitive with the questions that you ask to the uncertainty of what that relationship is until it is revealed.
Just if you ask them and you think like there's something else going on that they didn't originally say, you wouldn't necessarily feel like it would be best practice to push that, or what would be the sensitive thing to do?
I think in that situation, I would use the question. I always just ask all the folks that come in here what the relationship is with the child, and that sort of gives you an open door into that.
Yeah, Chad, would you say, are you the other mother?
I don't think that's not been traditionally how I've done it in those situations. I don't think it would be offensive or wrong to necessarily do that, but usually I let the individual bring it to me before I sort of make an assumption.
I think actually these sorts of practical examples are really good because it's, conceptually you can sort of be there and be ready to practice in this way, but in the actual situation to have practiced this, I'm kind of curious, is this sort of scenario been ever a part of a standardized patient exercise with students?
Let's see. So we do a lot in our medical training and the new curriculum. We have a lot of interaction with standardized patients and working with the simulation centers. And we do have cultural sensitivity training specific to LGBT health issues where we talk about the importance of these issues. So it certainly does come up throughout the curriculum.
So I have an uncle who so fits that profile. He's in his 70s. He's in a really large assisted living facility in Arlington, Virginia. It's like 8 stories. And my mother, who's a very elderly lady herself with a lot of illnesses, has been his the administrator in his will and his healthcare proxy. She cannot do that anymore. She's not able physically to do that. So I actually went to visit him because no one in the family had actually gone to visit him for a long time, and he was unable to visit us. So, I always knew he was gay, but no one in the family would ever use that word. He would never use that word either. So I went to find him. It was a very good conversation, and that we had a lot of time just to catch up with family issues. And I actually said, now we're going to talk about your advanced planning, because it's the time. We really need to do that. I'd already talked confidentially to the attorney who had made his will, and knew that they were willing to work with him to revise everything. But I was trying to get him committed to doing it. And it took hours just to walk through it with him and say, now this is really what you need to do with the proxy and the will.